format for our grand rounds with this. It's still been a great way to connect people. You know, I'm looking already close to 90 participants in this grand rounds, as opposed to often 60 or 70. So I'm glad people are logging in and getting engaged. Just want to thank everybody for their incredible work here over the last several weeks. Yesterday, we saw typically 90% of our usual volume of patients in clinic, and we did that 60 some odd percent through virtual visits. So, you know, Brandon, Nathan, Aaron Deo, everybody working in the clinic's been fantastic. And the hospital has continued to hum along. So I want to thank everybody for their hard work. Know that people are available. The department staff is still working and available to you. Just connect electronically. With that, I'll turn it back to Dr. Borman-Schill. Thank you all.
Thanks, Joe. So just for those who are logging on, the format of today's Zoom is what's called a webinar. So it's a little different than the Zoom meeting that many of you have been familiar with. So you'll hear audio from people who are designated as a panelist in the meeting. At the bottom or side of your screen, depending on what sort of device you're using, there's a little button called Q&A, and that'll be a great place to put in your questions. We will answer those at the end of the talk like we usually would at Grand Rounds, but you can put the question in whenever it comes to mind. We do have the chat window open, but it's just for the panelists today. So if there's a technical difficulty or something you want us to know about that doesn't fit into the question and answer category, you can certainly send it there. And if we have time at the end, when the questions are done, I'll open up the chat to everyone so you can send a little well wishes to everyone through the chat. So without further ado, I'll turn it over to Kathy Bendel, who can introduce our speaker.
Good morning, everyone. On behalf of the Division of Neonatology, it is my distinct pleasure to welcome Dr. Jennifer Fang from the Mayo Clinic. Dr. Fang is the neonatologist who went to the Mayo Medical School, then after that went out to Stanford for her pediatric residency training. Then she came back to Mayo for her neonatal fellowship training, followed by additional training at ASU to obtain a master's in the science of healthcare delivery. And this is some of her training that she's really capitalized on most recently. She serves as the medical director for Mayo Clinic's teleneonatology program. And my sister, who works very closely with her, says she has made this a really stellar, top-notch, exciting program. And she is really it. So even though we planned this Grand Rounds last fall, before we were doing everything remotely, it turns out to be a really extremely timely topic for our first standard Grand Rounds in this format. So Dr. Fang is going to talk to us today about using telemedicine to support neonatal resuscitation. Welcome, Dr. Fang.
Thank you so much for that kind introduction, and it has been such a joy to work with your sister, so I'm glad to hear it's mutual. But I agree that as we've been living through this COVID pandemic, it really has shifted, I think, how all of us are thinking care delivery and what opportunities we have to really be using virtual care more to meet the needs of our patient. And as you mentioned, my talk today will really focus on how we've been using telemedicine to support neonatal resuscitations that are happening in our smaller community hospitals. So I just have one disclosure, which is that intellectual property with InTouch Health. I won't be discussing any off-label use or investigational use during the talk today. So over the next 40 minutes or so, I just want to open by sharing with what it was about how the healthcare delivery system was functioning with respect to disparities in neonatal outcomes, which really drove the development of our telemedicine program here at Mayo Clinic. And then I'll move on to how we've used telemedicine to improve access to care, patient safety, as well as patient triage. And then I'll close with some of the early evidence we have that shows that telemedicine seems to improve the quality of these high-risk resuscitations that are occurring in community hospitals. So I wanted to start with a story. I realize people watching maybe at different levels of their training or on staff, maybe different specialties, but just for a moment, I want you to imagine that you are a pediatrician in a community hospital that has a level 1 well baby nursery. And it's February in Minnesota, and you're at the hospital covering, and you get called to the delivery, to labor and delivery, because a mother has presented in spontaneous onset preterm labor at 26 weeks gestation. And February in Minnesota last year, it may be during the midst of what we called Snowmageddon. And so despite wanting to move that mother, you can't because she's nearly fully dilated. Despite wanting to get the neonatal transport team present for that delivery, they need to go by ground and they aren't going to be there for the resuscitation. So it is on you as the general pediatrician to now resuscitate a 26-week, extremely preterm, extremely low birth weight infant. As the pediatrician in a community hospital, you may not have done this for years. You are probably thinking through what all will need to be done to resuscitate and stabilize this baby for ventilation, need for advanced airway, keeping the baby warm, securing access. And you can imagine how the anxiety, the stress, and the pressure you would feel with that situation. Think about how that changes if in that situation, you know you also have a neonatologist can be present with you in real time via an audio video connection, that neonatologist can be looking over your shoulder, guiding you through this high-risk resuscitation step by step, and troubleshooting when things may not be going according to plan, and really moving the care forward while the team is en route. I think that really changes the paradigm for how we deliver babies in this setting. And in fact, not surprisingly, this was one of our cases where a 26-week infant was delivered in a small community hospital. The team couldn't get there in time because of weather. And so our neonatologist assisted that local care team through the resuscitation. And this little one, Haley, spent about 2 or 3 months with us in the NICU. She had a very nice course, did very well, and at her NICU follow-up clinic was doing excellent with respect to growth and development. These are the stories that really early on pulled our neonatologists into the difference they were having. So now, as we think about what it is about the current healthcare delivery system that again drove us to develop the program, I think all of us, whether you're a neonatologist or a pediatrician or a specialist, recognize that when we can regionalize care and including perinatal care and get those high-risk mothers to hospitals like U of M or Mayo, where we're ready to deliver the level of care that mother needs, we can secure better outcomes for both moms and their newborns. That's been very well shown in the evidence in the literature. But we also recognize that we can't get all of those high-risk moms to our high-risk centers, that there may be geographic barriers, weather barriers, there may be social barriers, economic barriers that don't allow that to happen. And so when these high-risk deliveries, particularly our preterm babies, deliver in hospitals with lower levels of care, we know that those babies actually are at higher risk of morbidity and mortality when delivered in that setting. And I think we're all familiar with our state and where all of our NICUs are located, where we can get our high-risk mothers. But we have a large rural component of our state as well. And I think many of us know that especially in the Northwest region of our state, we have issues with infant mortality rates that are 20 to 30% higher than the more urban and suburban areas of our state. Now, when you look at the literature, this was a meta-analysis that was published now, oh my gosh, almost 10 years ago, but looking at our very low birth weight infants, so infants born at less than 1,500 grams. It included about 28,000 VLBW infants, and it was comparing the risk of mortality for very low birth weight infants born in a NICU versus born in a hospital without a NICU. And you can see when these VLBW infants are born in a hospital without a NICU, they're at a 60% increased odds of mortality. So, I mean, this is quite a striking disparity. And then if you look at those similar babies and the ones that survive, they are at increased risk of serious morbidities as well. So this is work that we published last year where we did propensity score matching for neonates born at less than 29 weeks and looked at differences in what you can see in these babies: increased risk of severe intraventricular hemorrhage, retinopathy of prematurity requiring treatment, as well as necrotizing enterocolitis. Now, when we think about what we're asking of our pediatricians or family medicine colleagues in these community hospitals when a very low birth weight infant delivers or a baby who needs advanced resuscitation, this is quite a challenge for them, because if delivery volumes are low, which they generally are in these settings, and they're not frequently performing advanced neonatal resuscitation, we know that those neonatal resuscitation skills really start declining in a matter of 2 to 3 months. So while our colleagues are doing their NRP training and maybe doing simulation, we know that when these skills aren't frequently used, then they aren't performed as well as they could be. And in fact, if you survey providers in rural hospitals, they will easily report to you how infrequently they're doing that they may provide positive pressure or ventilation only 1 to 3 times every year, which we all know that ability to provide effective ventilation is really the key critical component. So these events are very infrequent, but they're very high risk. And so we really wanted to think about how do we better support these providers in these hospitals, because we know everyone's doing their best to get, antenatal transfers done when possible to get moms to the right centers. That again, people are doing, their NRP training using that evidence-based and team-based approach to neonatal patient. Doing great team behaviors with briefing prior to deliveries, debriefing after so we learn what worked, what we need to address and improve. Building in simulation with neonatal mock codes in the hospital. But despite all these things that people are working to do to improve the quality of care they deliver, we know that we still are seeing this outcome disparity for our neonates. So that's why we asked the question, can we close the gap using telemedicine? Can we use this technology, this delivery model, to take the expertise, the experience that's in our NICUs and get it out to the bedside of neonates when they need it, when they're born in a community hospital? And so as we were thinking about this, I can remember the meeting when I was with our division chair and somebody within our quality academy, and he asked, well, why don't you guys just do it? Why don't you just start? And we kind of looked at each other and we said, well, because we don't know as if anybody's doing this. We don't know if it's feasible. Is it going to be effective? And so that's what first took us to our simulation center. And we started with a simulation study, and we had 46 of our pediatric residents came into the sim center, and we assigned them to either be the sole bedside provider, kind of that head of the bed role for a simulated resuscitation, or they were head of the bed with a video from a neonatologist. And then we basically presented them with a scenario, relatively straightforward. You're called to a vaginal delivery, term infant due to fetal bradycardia. Upon delivery, apneic, bradycardic with a heart rate of 70. And the objective of the scenario was for the participant to achieve effective ventilation. And they could do that in one of 2 ways. They could perform those first 5 corrective steps for ineffective ventilation, so making sure the mask was well positioned, repositioning the head if needed, clearing the airway, opening the mouth, increasing pressure. or they could intubate the patient. And so what we found was in a simulated setting, when the neonatologist was present via telemedicine, the time to effective ventilation was significantly reduced by 35%. And what was interesting was how the participants in each group achieved effect. It is very interesting. So all of the participants in the control group proceeded to endotracheal intubation to achieve effective ventilation. They couldn't, in the simulation, recall and perform all of those first 5 steps. So when the infant remained bradycardic, then they would proceed to intubation. Versus in the intervention group with the neonatologist there to provide, that guidance, they could achieve effective ventilation simply through those corrective steps. So from the simulation study, we basically learned that, at least, again, in a simulated setting, telemedicine seemed to significantly reduce the time to establish effective ventilation and improved adherence to the NRP algorithm. So this was just that little bit of reassurance or push that we needed to say, well, maybe this really would be a way for us to support our local providers during neonatal emergencies. So from there, we said, okay, let's give it a shot. And we, developed a pilot program, which has grown, over the last 7 years. So we now have a telemedicine network that allows our neonatologists here in Rochester to be at the bedside of critically ill neonates when we're needed. Again, I just briefly mentioned our program's about 7 years old now. We've performed, I think we're almost near our consult number 500. And we're fortunate because we've been able to really work to build this program between our Division of Neonatal Medicine and Mayo Clinic Center for Connected Care. So it's the 9 neonatologists who staff our level 3 and level 4 NICUs that provide the telemedicine consultations. And so for our practice, this was really relevant because when, in our NICUs, when we look at the patients, only about half of our patients are born here in Rochester, and the other half of our patients are coming in from outside hospitals within our surrounding region. So it was those outborn infants where we really wanted to see, can we help that baby? Can we help the local care teams before the baby even reaches our NICU? So our program now serves a total of 19 sites. Most of these are within Mayo Clinic's health system. So that includes 9 hospitals that have nurseries, so either a level 1 well newborn nursery or a level 2 special care nursery. And then we also support our Mayo Clinic hospitals that have emergency departments for when mothers present into the ED for delivery, or if they have a neonate present to the emergency room, then we can assist with those ER providers as well. We have 1 external site that participates in our program, and we're going to be bringing up our 2nd external site here within the next month or 2. So all told, our program covers about 6,000 deliveries each year. When you think about the type of care we're providing via telemedicine, I think to all the neonatologists out there, these diagnoses are going to look very familiar. It's very much the same as to what we do within our own practice here in Rochester, that we manage a lot of respiratory distress, whether it's TTN, meconium aspiration, pneumothorax. We work a lot with patients who are experiencing respiratory distress, help with the management of babies born preterm, whether it's a 23-weeker or a 34-weeker, we're assisting those local care teams. We get consulted for physical exam findings, whether it's a baby with abnormal movements and they're questioning seizure, whether it's a skin finding and they're not sure if the baby needs to come to the NICU for further evaluation. It's been very helpful for our babies who require advanced resuscitation, or we have question about encephalopathy, being present for that resuscitation so we know exactly what's been happening, making sure the right things are happening, with respect to whether it's ventilation or perfusion, obtaining blood gases, ability to do a neurologic exam. The telemedicine program has been very helpful for that. When you think about the gestational age of the babies we're caring for. I think many people think, oh, it's going to be a lot of preterms, but actually when you look at it, most of the babies we're consulting on are actually our term babies. So it's about 30% preterm and 60% full-term babies that are receiving consultations via telemedicine. And you can see the breakdown based on gestational age category there on the right. So with that, I wanted to pause, and I am going to exit out of my presentation here, and I want to share with you a video of a simulated teleneonatology consult, so you can get a sense of how this goes, how well we can interact with the local care team, and the guidance we can provide virtually. So I'm going to go ahead and share this, and hopefully
Clinic Commissioner Transfer Center, this is Chad RN. How can I help you?
Hi Chad, this is Julie. I need an emergency telemedicine consult for a preterm infant going to be born in Austin.
Okay. I just sent the page to our neonatologist, and I need to confirm you're calling from MCHS Austin, right?
Yes.
And briefly, what's happening with the baby?
We have a 28-week infant that will be born soon. Okay.
So, and that's our physician calling here. Let me put you on hold, and I'm going to get us connected, okay?
Okay.
ATC, this is Chad.
Hey, Chad, this is Bill Carey from Neonatology.
Say, I have Austin on the line. They have a 28-weeker that's not been born yet, and they want a teleneo conference. Can I connect you?
Yes, please. Thank you.
Okay. Go ahead. I have Dr. Carey on the line.
Hey, this is Bill Carey. I'm in Rochester. I understand you have a telemedicine consult for a 28-weeker.
Yes.
Okay, great. Hey, Chad, can you do me a favor and dispatch the neonate team down to Austin, and I'll connect via telemedicine right now.
Okay. Well, good.
Thank you. I'm going to stay on the line here until I'm connected, and I am live on video.
We have you on video.
Okay, thank you.
Thank you.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic, Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure. I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie.
I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right, and we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our Neo wrap set and ready to go, and I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'll go tend the baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic.
Puts that monitor on here.
We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
Heart
rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt the head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe 50 to 60 times a minute.
2, 3, breathe. 2, 3, breathe. 2, 3, breathe. 2, 3.
How's the heart rate, Julie?
Heart rate's still 70.
Huh. I'm not seeing very good chest rise right now, so Lindsay, can you increase the peak inspiratory pressure up to 25 for me?
Okay.
How does that feel, Dr. Fang?
We're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
Great. How's the heart rate, Julie?
Heart rate's still 70.
Huh. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than 100.
They're at 72.
Okay, so coming up.
Yep.
And spontaneous breathing looks like it's starting to happen. Kind of intermittent.
It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep our
so.
attitude where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So
baby's
it looks like the
breathing.
baby's breathing pretty well.
Yeah. Yep.
Excellent. Saturations, Lindsay?
80.
That's great. They're moving in the right direction. Heart rate?
Heart rate's still greater than 100.
That's excellent.
And we're almost 3 minutes old, Dr. Carey.
Okay, perfect. So, look, I just got a page from our transport team. They're about 20 minutes out. Maybe one thing to do at this point would be to check a blood sugar, and if you can, place an IV to start some dextrose fluids. Does that seem like a good idea?
Yeah, I think we can do that. Thank you. Baby's still breathing well.
Perfect.
Great.
So hopefully that was a way to illustrate what we can do with getting the neonatologist there to really work closely with that local care team during a resuscitation of a preterm infant. So I'm going to go ahead and switch over when I need to. We'll see. I think I'm going to switch over to the presentation mode. You have to give me 1 second. There we go. And screen share. Great. Okay. So I'm going to have to work my way through the slides quick. Except I'm not going to make you guys watch all of that. So let me get through back to where we need to be. Perfect. Okay. So I'm going to share with you guys. Let's see if this. Okay. Hopefully you should be seeing a picture of the Mayo Clinic Health System Midwest region. So when we think about the value that this type of program provides, I think one of the fundamental things that we're able to do with telemedicine is to enhance access to specialty care. When we look at our Midwest region here, where Rochester's in the middle, and those red numbers are the delivery volumes for our smaller community hospitals, when you think about access to care, less than half of the neonates delivered in our Mayo Clinic Health System region had immediate access to a neonatologist if they needed it, whether it was for resuscitation, for a change in clinical status that required consultation. Really kind of only the patients who were in Rochester had access to that. But with expansion of our program through telemedicine, we can now reach 100% of the neonates within the Mayo Clinic Midwest region. So regardless of birth location, if a term baby is delivered after a mom presents with placental abruption and that baby needs advanced resuscitation, we can connect with that pediatrician to really provide that level of specialty care through the video platform. So in addition to thinking about value with access to care, we also look at the impact on patient safety. And the metric that we follow for that is settled birth injury cases. I think any neonatologists in the group and other pediatricians as well recognize that labor, delivery, and newborn resuscitation can be high risk and highly litigated. And when we looked at our Mayo Clinic Health System and we looked at the frequency of settled birth injury cases before we had the program in place, on average, we would only go about a year between settled birth injury cases. Sometimes we go 2 up to 3 years. Sometimes we'd only go 2 or 3 months between settled birth injury cases. But since we've had our teleneonatology program in place, there hasn't been a single settled birth injury case in our health system. We've gone over 7 years without a settled birth injury case, which is the longest period of time we've gone in over 15 years. So it seems that by having the neonatologist there during these high-risk resuscitations, we're really able to make sure that that local care team, when they may be experiencing a high level of stress and anxiety due to the acuity of the situation, we can be there to still make sure that they are following the standard of care, following our evidence-based practices, and delivering the best care that they can to that baby in that setting. And so obviously this is, I think, very huge for ensuring that we're providing safe care for these infants regardless of delivery location. So I think huge for these babies and their families. Obviously, from an organizational standpoint, also very impactful if you happen to be talking to your administrators. But we think this is really our metric that's showing the impact on patient safety. The other thing that we found that is very valuable about telemedicine with that ability to visualize the infant is improved patient triage. That instead of trying to determine over the phone in discussion with our family physician about, how much distress is this baby in? Does the baby need to come to the NICU or not? Trying to figure out if their perception of respiratory distress is similar than mine. When you can connect via video and see that baby and work with that team, it is so helpful. I can see how much is that baby working. Are they grunting? How bad are the retractions? Are they just a little tachypnic? I can help them with troubleshooting. Have you cleared, have you suctioned? Have we made sure that there's no obstruction? Let's go ahead and try some facial CPAP to help that baby transition. That's where there's a lot of value. And so when you look at the patients who receive a teleneonatology consult, actually about 1 in 3 is able to stay in that birth hospital after the consultation. And then again, about 2 out of 3 ultimately come to the NICU to receive a higher level of care. But again, the value here with being able to keep babies in the health system is huge. It's huge for obviously the baby and the mother because we're not unnecessarily separating that dyad and we're not performing unnecessary medical transport. So when we think about resource utilization and utilization of the transport team, we're doing that efficiently versus when we admit babies who during transport end up transitioning and come to the NICU, breathing comfortably on room air. We see much less of that now. And then from a NICU standpoint, it's very nice because obviously we want our beds filled with babies who require critical care and not babies who are preparing for discharge home. So again, great value when we think about patient triage. And then the last thing here that I want to cover over the next 10 minutes or so is the work that we did to start looking at impact of teleneonatology on the quality of resuscitation. So we did a retrospective cohort study that we published now, a year and a half, 2 years ago, where we looked at our outboard neonates that were admitted to the NICU, and we compared neonates who had received a teleneonatology consult to matched controls who were managed by the local care team. And then we looked at the overall quality of the resuscitation. So we identified the patients, we knew our intervention, and then we matched controls based on gestational age, admission diagnosis, level of care at the birth hospital, gender. And then for each of those patients, we went into the electronic health record and abstracted relevant patient characteristics and various resuscitation metrics. And then we had 2 of our neonatologists who were blinded to intervention or control for each patient, review the characteristics, the resuscitation metrics, and then rate the quality of that resuscitation on a 1 to 10 scale. And the neonatologists in the audience will recognize that we don't really have a validated scoring tool for quality of resuscitation. So we had developed a descriptive scale, 1 to 10, that basically on a scale of 1 was that resuscitation showed significant deviation from the standard of care. Metrics were never measured, or if they were very abnormal, versus 10 being that high quality resuscitation, excellent, no room for improvement, something we would all be proud to be a part of. So when we look at the infants who were included in the study, on average, they were about 35 weeks gestation, though you can see 15 to 20% were less than 29 weeks. On average, they weighed about 2,500 grams. But again, with the range in birth weights there, you can see we had some small babies as well, weighing 500 to 600 grams. Now, similar to what I mentioned earlier, many of these babies, their admission diagnosis was prematurity or respiratory distress syndrome. And we also saw many who had encephalopathy. Now, exposure to antenatal steroids for babies who were candidates was quite low, which again, this is the outborn population, and many of these mothers are presenting emergently. And you can get a sense of the urgency of these deliveries when you look at the rate of emergency cesarean section, so 30 to 40%. So again, these were often moms coming in with abruption, cord accident, precipitous onset of preterm labor, things that prompted a rapid delivery, hence delivery in a community hospital. So when we then look at the primary outcome, which was the quality of the resuscitation, what we found was that the quality was significantly improved for neonates who received a telemedicine consultation. You can see the median quality rating was 7 in our telemedicine group compared to 4 in the control group. And when you look at the percentage of babies who had a higher score, so 5 or greater, you can see a greater percentage of babies in the telemedicine earned that higher rating. Then we did a sensitivity analysis to look at timing of the consultation. So if we just looked at the matched pairs where the consultation occurred in that golden hour, that first hour after delivery, it seems like we can have a greater positive impact the earlier that we're engaged. So you can see the mean rating for the telemedicine group went up in this cohort. And then when you look at the percentage of babies who had a quality rating of 5 or greater, again, there was a greater difference between our intervention and our control group. Now, if we look at what was it about the neonates in the telemedicine group that likely earned them that higher quality rating, it was really process metrics. Neonates in the telemedicine group were more likely to have their temperature measured, their blood glucose measured, and their blood gas measured than the neonates in the control group. And, again, and when we think about these things, I mean, these are important. We need to make sure, especially our preterm babies, aren't getting hypothermic, because we know hypothermia in the delivery room is associated with increased risk of mortality. We need to make sure we're maintaining euglycemia, or if the baby's hypoglycemic, identifying that and treating that. We need to ensure that we're adequately ventilating our babies, that we're not hyperventilating them or underventilating them. So again, the babies are more likely to have these things done and checked when the neonatologist can be there via video to provide those recommendations. And the last thing I want to touch on here before we go over Q&A and discussion was the information that we have on feedback from our local care teams and from the neonatologists. So after each consultation, we send a link out to an electronic survey that assesses, what the consultation was for, how our technology performed, and how we performed as a team. How did the neonatologist work with the local care team and vice versa? And you can see, I mean, these numbers are quite high, that when we're asking our pediatricians, our family medicine colleagues about the program, they do use it, and they use it again and again, that they feel like the remote neonatologist is collaborating well with them, that we're seeking information from them, and when we're communicating, we're providing brief, specific, clear instructions that they can manage and put into practice during the resuscitation. When we survey our neonatologists, they feel like they're achieving a shared mental model with that local care team, that they know, what's happening, what are the next steps that need to happen in the care of that neonate. That when they're joining the resuscitation, that they're getting that, briefing so they know, what's going on, what's already happened. And that information sharing via telemedicine has been rated quite high, and that we feel when we're engaged in these consultations that we are a member of that resuscitation team. So in conclusion, hopefully over the last 40 minutes or so, I've been able to share with you what it was about system level performance and the outcome disparity for our at-risk neonates that was really the driver for the development of our program. And that we've shown how we've used telemedicine to improve access to care, to really enhance patient safety, even for our high-risk neonates born in a community setting, and to really facilitate optimal patient triage and appropriate utilization of beds in our community hospitals versus in our NICUs. And then at least early evidence that seems to show that teleneonatology can enhance the quality of these high-risk resuscitations that are happening in our more rural hospitals. And so with that, it looks like we have some questions on Q&A, so I think I'll go ahead and transition to seeing what you guys have about what we've been discussing thus far. So looks like the first question is, can you use telemedicine during transport with your system? So we don't currently have transport in our ambulances or in our aircraft. We just have it in our community hospitals. So we don't do it during transport. That being said, so I also serve as medical director for our transport team, and when I chat with our transport nurses and respiratory therapists, they, without a doubt, recognize the difference in the patients they're going to retrieve before and after teleneonatology. And it's something I really need to study and with them, but they often comment about when they go to pick up that baby, that baby is so much more stable than previously, that when the neonatologist has been there, they're now coming to babies who are, have appropriate, vascular access, who are appropriately ventilated and saturated, whether it's via PPV, CPAP, or intubation. So they have really seen the impact. And hopefully in the next 6 to 12 months, I'll have more data on that as we're enrolling, prospectively enrolling our outborn babies in a study that's looking at the TRIPS score, so the Transport Risk Index of Physiologic Stability. We're comparing the TRIPS score when our team arrives at the outborn hospital between neonates who received a telemedicine consult and those who didn't. So hopefully we'll have a little bit more information about that, but not currently using it during the transportation. So the next question was, do you find that more babies are able to stay at their site of delivery versus transport, assuming that they don't require increased level of care associated with their diagnosis? So I shared a little bit of that. The data we have is just on our teleneonatology consults. We haven't done the comparative analysis of babies who received telemedicine versus babies who did not, and the rate of transport. We haven't done that. It's going to be challenging for us to do that now, because I'd have to go back over 7 years ago to get controls, because so many of our outborns received telemedicine. That being said, Intermountain Health did do a comparative analysis that they published in Health Affairs 6 to 12 months ago. And what they found was that the rate of transfer to their NICU, there was a reduction in the odds of transfer by about 30%. So they've done that work. We haven't done the comparative analysis yet. Ooh, can I comment on cost effectiveness? Oh, that's a fabulous question. So not yet, though we are in the midst of actually doing a cost effectiveness analysis that we've designed. So we are going to be looking at the cost per adverse outcome averted, is from the perspective of the healthcare delivery system. So as we think about the cost of the program versus the cost savings associated with the program, what does that look like when we think about averting adverse outcomes, whether it's mortality or serious morbidities? So I can't comment on that yet, but again, hopefully soon. There have been not true formal cost effectiveness analyses published yet on teleneonatology. In some of the papers, including the paper published by Intermountain Health and Health Affairs, in the discussion, there's comments about that. So for example, when they looked at reduced odds of transport, they said, okay, what is the cost savings associated with that? If we're reducing transport, knowing the cost by ground, by air, the cost of NICU stay versus community hospital stay, they estimated, I think, a cost savings of, $1.2 million over a 12-month period. So that's about where we're at right now for the level of evidence. So definitely a gap there that needs to be addressed. Let's see. Oh, God, you guys have so many great questions. Was there a learning curve for your neonatologist? If so, what skills improved with more experience? Yes, there was a learning curve. I can easily say that. When we started, nobody was really doing it, so we kind of just jumped in, and we learned what along the way, what worked, what didn't, and it improved over time. I think some of the key things that we learned were, I think, first, as neonatologists practicing in our setting, I think we're very used to having many team members who are highly skilled with plentiful resources. So, when we go to a delivery and we have 8 people there, we can ask for 10 things at once, and that happens. But obviously that is very different than what our colleagues are working within the community hospitals, where, you might have 1 or 2 nurses, a pediatrician, they may try to pull in a CRNA. And so what we learned was the skill of prioritizing what we needed and pacing our requests so that it was manageable by that local care team. So while I might want, a chest x-ray and a blood gas and to hear more about whatever the antenatal history, what's most important now is, this, and then I'll ask for this. So I think there was a lot we learned about that pacing and prioritization that was helpful. And then now that we have been practicing, for example, when Dr. Bendel Stenzel joined our practice, it was hopefully a bit easier for her and a smoother transition as we onboard our new consultants, because now we have a few modules that we share with them and review with them that talks a bit about the practice, the workflow. We have one on website manner that we use, and then some basic compliance information. And then we also, before we, go right into clinical consultations, our consultants participate in simulations. So that's very helpful. A lot of our community hospitals will do simulations that include teleneonatology. And so then we'll bring our new consultants or fellows into those simulations so they get a chance to practice what it feels like to do the teleneonatology consults and actually get feedback too from the local care team about what worked well, what they can do better. Let's see. Is there legal precedent on the liability in using telemedicine? Is there state-to-state variability? That's also great and common question. So a formal legal precedent, I'm not sure I can speak to what are the discussions we've had with the Mayo Legal Department, which for all of the sites within the Mayo Clinic health system, that is all under the Mayo Clinic enterprise umbrella. So from an enterprise perspective, it's not increasing our institutional liability because it's all part of Mayo Clinic. And in fact, based on what we've learned about our settled birth injury cases, it's actually reducing the enterprise liability by having this program in place. That being said, obviously on a individual level, the neonatologists are now participating in more resuscitations, which is increasing their exposure to liability. But again, what we found, because we have the expertise and the experience, we're actually making sure that care is being delivered in a way that is standard of care and evidence-based, so liability is reduced. For our external sites, within our contract that we have with external sites, our lawyers and our contract managers build in kind of, I think it's pretty routine indemnity language that's built into the contract as well. And since we've had our program in place for the last 7 years, we haven't had any cases come up with respect to teleneonatology. So for what that's worth, over 7 years, there's been no legal action involving the telemedicine program. Oh, yeah. Boy, I could do this for hours. Do you do dry runs or simulations with your remote sites after setting up the system before going live? Yes, we do. So that is part of the training of the sites. When we look at how we implement teleneonatology at new sites, that is part of the implementation plan. So they, we do everything with respect to device, delivery, setup, burn-in, training of the staff at the community hospital, and then we do a series of simulations. Normally it's anywhere from 3 to 5 simulations with that site. So they get to practice service activation, they practice setup of the technology, they get to engage with a remote neonatologist, and that has been very helpful, I think, for getting comfortable with the new model and really recognizing that we're there to help and support and provide guidance in a way that's hopefully much more effective than the previous 5-minute phone call. Let's see, we have a few minutes. It looks like the home hospital needs a designated room with the video equipment installed near the warmer. Can you talk more about what the home hospital needs and the CQN you connect over a mobile device? So the home hospital. So in our community sites, the device that we use, the product that we use is a wireless telemedicine cart. So it's not like you need one in every room. So our hospitals have one device. It is constant, it's always on wireless network. And the product that we use, the vendor is able to ping that device every 2 minutes. So they know the device is on and it's connected to the network. Then the local care team, if they have a delivery where they're anticipating they might need us or they need us, then that telemedicine device is brought to the bedside, generally positioned at the corner of the resuscitation bed. And then it's really, they put it there, they lock the wheels, they raise it up, and then they're good to go. So it's pretty easy to use from the perspective of the local care team, which when we went through product selection, which this is our 3rd iteration of technology, that was really important because obviously those local care teams are very task saturated, right? They have this baby requiring resuscitation. They're trying to manage all of that. They don't have capacity or bandwidth to manage telemedicine products. So we needed to make sure we selected something that was very easy for them to use. And then from our perspective of the neonatologist, with a product that we use, any of our workstations, we can connect to a site from any workstation. So we have the software that we need installed, and they all have, webcams and headsets. So I can just go to my nearest workstation, log in, launch the software, which you kind of saw a little bit in the video, and then connect to the device and then provide that consultation. In our practice, we have the option of taking call from home still. So each of our neonatologists also has a setup at home in their home office. So if I'm taking call from home and I get a call at 2 in the morning, then I can go down to the office and then do the consultation from there. So hopefully that answered that question. Let's see, the next one was a very kind comment. Thank you very much. And then having experienced this firsthand during my time at MCHS, oh, thank you. I can vouch that it's an extremely comforting having the neonatologist guiding you through the resuscitation and providing the validation of your efforts makes a world of difference. Thank you for an outstanding program. Oh, thank you. Hopefully, I'm glad to hear that what we're hearing in surveys and our discussions really rings true. So do you utilize your telemedicine to assist with resuscitation in your system of care with an APP on site for certain deliveries? So where you do not have a neonatologist. So we're assisting hospitals. So our hospitals that have level 1 or level 2 nurseries, the staffing model varies, but our hospitals with the level 2 special care nurseries do have pediatric hospitalists who are generally in-house. And so when we connect to those sites, we're working with our pediatric hospitalists. Some of our smaller community hospitals that have a level 1 well baby nursery, many of those are staffed by family medicine physicians who may be covering call from clinic or from home. And so when we connect in those situations, we may be starting with just the nurse if the physician is en route from clinic or home. And I can tell you in those sites, those nurses are the strongest advocates for this program because they're the ones who are really doing their best, but sometimes struggling a bit with what's happening. And so sometimes we're initially working with the nurse while the physician's coming in to the hospital. And then in our emergency departments, we are often working with advanced practice providers. Some of our critical access EDs or small community EDs may only be staffed by NPs or PAs. For example, we had in Bloomer, Wisconsin, a mother who presented at 30 weeks gestation, and that was to the ED. I mean, they hadn't delivered a baby, I think they said, for 4 years in that hospital. And this mom came in, precipitous delivery at 30 weeks. And so we connected with the physician assistant there and then the physician who was coming in from home. So we kind of work with can be anywhere from a NPPA or nurse up to, you know, the pediatrician. Let's see. Oh, are your trainings taking at your site taking part in teleconsults? Yes. So we have a program for our fellows that kind of spans the 3 years where they participate in teleneonatology, and it's kind of a graduated program. So we really give them their first year to get their NRP instructor status, to get some experience in our delivery room in the NICU, and then we have a few learning modules that we ask them to complete. And then in their second year, they start with the simulated consultation. So they'll start by observing and then performing supervised simulated consultations. And we have, you know, we evaluate them on their competencies that are kind of mapped to the ACGME competencies. And then once they demonstrate proficiency there, then they go to unsupervised simulated consultations. And they do that during their second year of training. And then if all that looks good and they're progressing well, then in their third year, they can provide supervised clinical consultations. So they're never doing clinical consultations independently. They're always doing them with a neonatologist who is also connected during the clinical consultation. So we've been including them, and I think the feedback from our fellows has been very positive. I think it's really good for them because they are getting exposure, number one, to the community hospital setting and really learning how care is delivered there, which is great. They're getting additional delivery room exposure in a way that they need to lead the resuscitation, not in I want to do the intubation and place the line, but making them step back now and take a leadership role during the resuscitation, which again, as they're making that transition through training, I think has been very valuable for them. Do you have an additional neonatologist on call to take calls? Yeah, that's a great question. So we do not have teleneonatology as a separate service line. So despite covering 19 hospitals, covering over 6,000 deliveries on average, we only have about 10 to 15 consultations per month. So it's not a volume that can really support a separate service line. So the way our staffing works, during the weekdays, we have a total of 3 neonatologists on, 2 in our level 4 and 1 in our level 3. So it's the second neonatologist in our level 4 who works with our NNPs, who covers the telemedicine consultations. And then at night, our neonatologist, they cover everything. So they cover delivery room, level 3, level 4, and teleneonatology, which sounds like a lot, but because we have fantastic NNPs, in both of our units, it's very manageable. For a while, we had a second neonatologist on call to support the first neonatologist at night, but it wasn't being utilized really, so we backed that off. And then on the weekends, we have 2 neonatologists who cover, and they back each other up. So that's really worked quite effectively for us, and we've had in 7 years 1 event where we had 2 activations come in at once, and then the neonatologist just had to pass that off to one of her colleagues. So that's where that's at. Have you learned of pediatricians that were involved in the telemedicine resuscitation become more skilled, confident in future resuscitations with or without telemedicine? It's a beautiful question. We have not studied that. I don't know. My gut and our experience seems to say yes, because the sites that use us, especially for simulations, when we're connecting, they seem to perform better, but we have not studied that. But it's an excellent question. And then last question here, because I know we're over time, is do we bill? Yes, we do. For our internal sites, where they're all under Mayo Clinic Enterprise and insurance is all sorted out, we do bill. Telemedicine billing is not straightforward. It's quite complex, but we write notes. We put in the billable elements that includes, the amount of time and the level of care we spent during the consultation. And then contrary to just like our day-to-day billing, telemedicine billing gets pushed out to our billers and coders who review what we did, where the patient was, did they get admitted, what's their insurance, all of that to select the appropriate billing code. For our contracted sites, we do not bill. We just have the paid contract for the service at the hospital. So with that, one more, is the video recorded? No, we don't record them currently. We're thinking about, can we start doing that for learning and QA purposes, but not currently recorded. So with that, I guess I will stop because it's overtime.